Good afternoon. Welcome to the Touro College and University System and New York Medical College 12th COVID-19 webinar. I'm your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. COVID-19 webinar number 12. We've been at these now for 16 months since our first program in January of last year. But the pandemic keeps providing us with additional twists and turns, both in the biology of the virus, in the public policy, and in the law. And so we continue to strive to bring you the most up-to-date information for you to formulate your own best opinions as a citizen, for your life at work as managers, and for those of you in the clinical disciplines for the care of your patients. In this program, as in our previous programs, we're going to have some of your old friends and some of your new friends. We're going to hear from the Dean of the School of Health Science and Practice at New York Medical College, Dr. Robert Amler, about whether there's ever going to be a light at the end of the tunnel of this pandemic, or whether we're on the pathway for the virus to be a recurrent seasonal disease. Dr. Kathleen DiCaprio is back with us from the Touro College of Osteopathic Medicine to teach us what we need to know about the side effects of the vaccines and how we ought to deal with them. Dr. Marissa Montecalvo of New York Medical College, who is board certified in infectious disease, is going to update us on some of the new forms of therapy, or at least alleged forms of therapy for the vaccine. Some of them have not proven to be particularly therapeutic. We have a new friend with us, Mr. Nicholas Janica, who's an attorney with New York Medical College, and is going to teach us about whether universities and corporations can require students and employees to be vaccinated or not. What are the evolving boundary conditions of that issue? Professor Murthy is with us from the School of Health Science and Practice, who's going to teach us about what we ought to know about the pandemic in India and how healthcare disparities in India have in part produced the fearful rates of mortality and morbidity in that country. And I'm going to be back later in the program to talk to you about the impact of the pandemic on the diagnosis and treatment of cancer. And then Dr. Alan Kadish, the president of the Touro College and University System, will appear on screen to moderate the question and answers for the program. So throughout today's program, if you have a question, go right ahead and type your question into the question and answer box on your screen. We'll be monitoring the questions and answers throughout the program, and we'll get to as many of them as we can when Dr. Kadish is moderating the Q&A program. If at all possible, please indicate which of the panelists you wish to direct your question to, but if you don't, we'll do the best we can to hand them out to the person best capable of answering your question. We hope you enjoyed today's program. We hope you find it useful, and thank you for joining us. Let's begin with the first of our panelists, Dr. Robert Amler, the Dean of the School of Health Sciences and Practice at New York Medical College.
Hello, it's good to be back. I'm Dr. Robert Amler. Will COVID ever end, or will it become a seasonal infectious disease? I have no conflicts to disclose. People often ask, why do epidemiologists like me always seem to know stuff or think they know stuff? Well, our specialty does give us a nice new dimension in which to view problems and analyze and report to decision makers. In fact, one of the reasons I love this field is because anybody can learn to do this. We start with case definitions because we need to know or agree on what precisely do we call COVID, what is not COVID, so that we can then count cases, do testing and tracing, and quickly move to rates, time, place, and person, and begin to make inferences that lead to recommendations. Those first four we've already begun to do, but now the organizers of this webinar has demanded me to make predictions on what's going to happen next. And the predictions made by epidemiologists are always going to be only as good as the accuracy and completeness of the data. The data, the whole data, and nothing but the data. And the data will go on this missing page that's still in draft form in this hypothetical edition, the next edition of the Control of Communicable Disease Manual by the American Public Health Association. Still in draft form, we have some of the areas, some of the categories complete, but what will be the effects now going forward of unmasking, reopening businesses, schools, and other areas, travel coming back, seasonal climate changes that at times seem to affect the incidence of infectious disease? And what about the variants of the SARS-2 virus that we keep hearing about and learning about? Well, let us reason together. We could think, is COVID going to become more like flu or like pertussis? We can compare across this table, beginning with the infectivity of the disease, which is expressed by this statistical metric called R0 or R0. But as we've discussed before in these webinars, R0 is not the be all and the end all for deciding what will happen. It's simply a reflection of how many new infections tend to occur after each infectious case. In the case of influenza, it's 1 to 3. Pertussis is even more infectious, 5.5 new cases for every infection. Currently with COVID, it's less than 1 new infection for every new infection, which means the epidemic, at least in the United States, is losing steam and it's declining. We know that in the case of pertussis, the organism doesn't change very much, but in the case of flu, and we're learning about COVID, it does change. The incidence rates are extraordinarily high in a typical flu year or in the current COVID year. Pertussis is far less common in a given year and leads to fewer deaths, where there are tens of thousands of deaths from influenza, and sadly, even in our country alone, more than 500,000 deaths from COVID. But the pattern is the most important part. In the case of influenza, we see an endemic pattern where it's pretty much always present. It rises and it falls, it rises and falls, but every year we have had a flu season. In the case of pertussis, it also comes and goes, but it comes more in spikes, particularly when an infected case lands in a community that has been lax about vaccinating their people, particularly their children and adolescents and young adults. COVID, of course, has been a pandemic, and we don't know how it will evolve. So we're going to have to wait and see. The vaccination policy for flu has been annual revaccination, typically with a quadrivalent product that is intended to try to reach what we think will be the 4 most prevalent strains or variants that need to be addressed. In the case of pertussis, we give a primary series in childhood, and then we revaccinate into school-age children and then into adolescents, and even lately now in pregnant women who should get a dose of pertussis booster during their pregnancy to give antibodies to the fetus so they will be born with some protection against pertussis. What do we need to do for COVID in the coming year has yet to be determined. And so what we are left with is we still don't know if COVID will end completely. It seems it probably will not completely end. But in the meantime, we should stay calm, watch the trends, and be ready to improvise because there will still be much more to follow. Thank you.
Hello, this is your host again, Dr. Edward Halperin, with information for those of you who wish to get continuing medical education credit. You have three options for getting your CME credit from today's program. You can text the code 14GYPS, all capital letters for the letters, to the phone number 828-295-1144. If you text that code to that phone number, you'll get a response back with instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit. If you don't like doing it that way, you can go to the website www.eeds.com, click on the sign-in button, and enter the same code. As a third choice to fill out your satisfaction questionnaire and get your CME credit, you can take your cell phone and snap a picture with your software of the QR code, and that will automatically take you to the place on the web to fill out the questionnaire and get your CME credit. Either of the three ways will work, but I would recommend you get about your business to taking care of this, because the code will expire on Tuesday, June 8th at 12:30 in the afternoon. Perhaps you want to take your phone out and now do a screenshot of this information, or maybe you want to write it down, or you want to go right ahead and do it now to be sure you get your CME credit. Now let's turn our attention back to our program.
Hello, my name is Kathleen DiCaprio, and I'm an assistant professor of microbiology and immunology at Touro College of Osteopathic Medicine in Harlem. Today, I'll be presenting some COVID-19 vaccine side effects and how they may influence decision-making. I have no conflicts of interest to declare. Now, before we discuss the side effects of COVID-19 vaccines, let's first better define vaccine adverse events. Now, any health problem that happens after vaccination is considered an adverse event. An adverse event can be a true adverse reaction, also known as a side effect, that's related to the vaccine, or a coincidental event. Now, coincidental events include health problems of a vaccine recipient not related to the vaccine or with an unknown cause. Now, regardless of whether an adverse event is a side effect or coincidental, all adverse events are and should be reported to the Vaccine Adverse Event Reporting System, or VAERS. And they'll monitor the safety of the vaccines. And using this system, data is organized for review by the FDA, the CDC, et cetera. And this is really important, especially for those vaccines under emergency use. Now, a quick review of the currently available COVID-19 vaccines in the US. These include 2 mRNA vaccines, the Pfizer vaccine that's available for anyone 12 and up and is approved as a 2 immunization or 2 shots spaced about 3 weeks. And then the Moderna vaccine available to anyone 18 and older, also 2 shots spaced about a month apart. Now, the Johnson & Johnson vaccine, which is an adenoviral vector vaccine, it's available to anyone 18 and older, and it's only 1 or a single immunization. So that's really nice. Now, there are several side effects that are common among all 3 of the COVID-19 vaccines. These include some local manifestations, arm pain, swelling, redness, and some systemic manifestations like fever, muscle pain, fatigue, chills. Now, the mRNA vaccines from Pfizer and Moderna, they also appear to have those same local and systemic side effects following receiving the second immunization, except with a bit more intensity compared to the first. That was my experience as well. Now, well, the common side effects are, well, common. These COVID-19 vaccines do have a few uncommon, or even rare adverse events, which are still being more thoroughly explored. For example, throughout the Moderna and Pfizer clinical vaccines, 8 cases of Bell's palsy, a type of rare sudden muscle weakness in the face, were reported in total. Now, interestingly, the rate of Bell's palsy incidence in the vaccine clinical trials was less than or equal to the rate of developing the condition in general. While there's no evidence that the cases were caused by the vaccine, they are considered an adverse event and will continue to be reported and monitored throughout the clinical trial and after. Now, the adverse events associated with the Johnson & Johnson vaccine have received a bit more attention as they led to a vaccine pause that allowed and was necessary for a safety review. And this was following reports of cases of a rare and severe type of blood clotting syndrome called thrombosis, with thrombocytopenia syndrome, with cerebral venous sinus thrombosis in most cases. So kind of a big deal. So let's take a little bit more look into this. Now, in a recent safety report from the CDC, it outlined that 28 cases of thrombosis, thrombocytopenia syndrome, or we sometimes call it TTS, they've been reported in the United States. Now, most cases, not all of them, occurred in women between the ages of 39 and 49 and happened about 6 to 15 days after the vaccination. Unfortunately, of those, 3 people died. Now, the review concluded that there is a plausible causal relationship between the vaccine and TTS. And because of this, patients now need to be informed of this potential side effect, as well as suggest to the patient that for at least 3 weeks following the receipt of the vaccine, the patients be on the lookout for symptoms of blood clotting with low platelets, such as severe persistent headaches, blurred vision, chest pain, leg swelling, abdominal pain, easy bruising. I've got them listed all right here for you. Now, in addition to the COVID-19 vaccine side effects, there are a few additional things that should influence decisions related to vaccination. Now, it's important to have appropriate medical discussion and or advisement about vaccinations if any of the following are relevant to you or your patient. History of allergy to vaccine ingredients or severe allergic reaction to vaccines in the past. And a list of the vaccine ingredients are readily available. History of blood clots, pregnancy, thinking of becoming pregnant or breastfeeding. History of condition that affects your immune system. Currently receiving radiation therapy or chemotherapy, and currently taking medications that affect your immune system. Now, before I conclude this presentation, I want to quickly highlight a few side effects or adverse events that many have had questions about, especially recently. So let's go through these together. Will the vaccines cause infertility? At this point, there's no evidence to support that these vaccines cause infertility. There was some suggestions a while ago that COVID-19 antibodies generated would react against placental antigens, but there's been no evidence to support this. Will the mRNA vaccines interact with DNA? No, the vaccines are messenger RNA or mRNA, and they work to instruct the cells to make proteins. The mRNA doesn't interact with the DNA. The cells break it down and get rid of it as soon after it's used to make the necessary proteins. What if I have an egg allergy? The vaccines do not contain any egg products. Will the vaccines give me a positive COVID-19 viral test? I get this one a lot. No, the vaccines do not contain the virus, which is what the PCR test looks for that we use when we get the virus test. But they will generate COVID-19 antibodies, and that suggests immunity against the virus, no infection with the virus. That's not what we're looking for. Will the vaccines affect menstrual cycles? Many things can affect menstrual cycles: stress, changes in monthly schedules, problems with sleep, changes in diet and exercise. The vaccines have not been associated directly with causing menstrual change cycles. Now, at this point, many people have received the COVID-19 vaccine. Some have experienced a side effect or two. Hopefully, for those who have not received their vaccines and are worried and considering and concerned about side effects, hopefully available information will continue and they'll consider vaccination in the future if it's appropriate. Thank you.
Hello again. This is your host, Dr. Edward Halperin, with a word from our sponsor. Programs like you're viewing today are free. Indeed, the continuing medical education credit is also free. But producing these programs is not free. The college spends a considerable amount of time and money arranging for speakers and slides and the information technology infrastructure to bring you today's webinar. For those of you who are inclined to give back to the college to help programs and research projects like the ones mentioned today, we hope you'll consider making a tax-deductible gift to New York Medical College, because your donation will help offset our costs. Great things are happening here at New York Medical College. We hope you'll want to be a part of it. There are 3 ways you could make a donation. You could phone us at 914-594-2720, and someone from the development office during business hours will be happy to take the information. Or you could go online at www.nymc.edu/give and electronically with a credit card, make a donation to support today's program and our COVID-19 research. Or if you like writing a good old-fashioned check with a pen, please make the check out to New York Medical College, write on the memo line, COVID-19 webinar, and put it in the mail to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking about us during these challenging times. Thanks for considering making a donation. Please stay safe, and let's turn our attention back to our program.
Good afternoon. I'm Marissa Montecalvo, and I'm speaking on convalescent plasma, vitamin D, and ivermectin. What have we learned? I have no conflicts of interest to disclose. So I think you're familiar with the concept that convalescent plasma is obtaining neutralizing antibody from patients recovered from COVID-19. And the purpose of this antibody is to block attachment of SARS-CoV-2 to its receptor, which is the ACE receptor. The schematic on the left here shows you how this works. Normally, virus binds to its cell receptor, and the neutralizing antibody binds it up so that it no longer fits. The graph on the bottom shows you the natural response to SARS-CoV-2 infection, your natural antibody response, which is during the first 5 days, you haven't yet mounted your own antibody. And thus, that is the period in which receipt of neutralizing antibody from a patient who has recovered from COVID-19 could be most beneficial. One of the issues is, how do you know that the plasma that is being collected has the amount of neutralizing antibody that you need? Well, the test to do that is very labor intensive. It's called a plaque reduction assay, where you grow virus in the plates on the bottom, and virus causes plaques in agar, and you want to see a reduction in those plaques because the antibody is binding up the virus. And so you see how much can you dilute someone's plasma and still get that standard reduction. So this is a standard test to measure neutralizing antibody, but not something that can be done in a high throughput blood donation center. So one of the things that has occurred over the past year is looking at surrogate tests that will correlate with the titers that you would see from a natural plaque reduction assay. And there's now a standard test that is used, an immunoglobulin G test, that is the test to screen plasma. So beginning from the beginning of the pandemic, there was a U.S. expanded access program to follow patients who received convalescent plasma. And between March and August, 94,000 people had been enrolled in that program. And this map shows you these centers across the United States. So what this expanded access program did is it created a database. Although the patients in it simply received convalescent plasma and there were no controls, it wasn't a controlled study, it was able to establish the safety of convalescent plasma. And from these data, they felt that it was potentially beneficial, and this led to the emergency use authorization for convalescent plasma use in hospitalized patients. But since then, we now have some peer-reviewed literature. So going back to the expanded access program in August, there were 94,000 patients enrolled, no controls. But if you look at mortality for those who received plasma early on after symptom onset versus later on, mortality was lower if you were transfused within 3 days of symptom onset, and mortality was lower if you received high titer plasma. So that is the information that came from this group. After that, there have been 5 RCTs, which is my acronym for Randomized Controlled Trials, and you can see the number of patients enrolled. Now, the first 3 here, the UK, India, and Argentina, no benefit was demonstrated. However, these trials all had problems in that patients received convalescent plasma late in the course of infection. So one of the issues is this is being given to hospitalized patients. So you have symptom onset, then you get hospitalized, then you get convalescent plasma. So they were receiving it 8 to 9 days out, and that's thought to be a limitation of the study. And in the Placid trial from India, it turned out the titer was actually a low antibody plasma. So that also was a confounding issue. I want to call your attention to this study, which had 160 patients, older patients who received high titer plasma, and here they were able to show a statistically significant reduction in the progression of disease. And lastly, the expanded access program did look retrospectively at a subset of patients of 3,082 patients, and statistically was able to demonstrate a lower risk of death for these patients if they receive that, for these patients that received high titer plasma and were not on mechanical ventilation. So where are we? Well, the emergency use authorization from August was modified in February to say that you cannot use low titer plasma. It has to be high titer plasma, and it really needs to be used early on in the course of hospitalization so that you're very close to the period of symptom onset. Could be later if someone is very immunosuppressed and you really don't think they're going to be able to mount their own immune response. In terms of the treatment guidelines, NIH says that there is still insufficient data for use, and the Infectious Diseases Society of America says it should only be used in the context of a clinical trial. What we have learned over the last year is a lot about who are the best donors. Patients with severe disease have higher neutralizing antibodies, and donating within 6 weeks of the first symptom of your COVID-19 infection is also the period of highest neutralizing antibody. I'm going to switch gears now to vitamin D, the sunshine vitamin made famous in part by our former president, who received it as part of his cocktail for COVID-19. There's always interest in vitamin D because vitamin D receptors are expressed on immune cells, and so it has the potential to modulate immune response. It's also been looked at in terms of respiratory viral infections in general, and there is a literature suggesting that it may prevent or improve outcomes. There is only one single double-blinded placebo-controlled trial that has been published, and there they were not able to show a benefit for COVID-19, either on length of stay or any clinical outcome. So at this point, the NIH would say that there are insufficient data to recommend its use, but there are further trials still ongoing. And lastly, ivermectin. Ivermectin is a drug which, if we demonstrate efficacy, could be very useful. It's a drug that is used worldwide to treat helminth infections, river blindness, strongyloidiasis. It's used to prevent heartworm in dogs. And it was shown in vitro to interfere with the attachment of SARS-CoV-2 to human cells and inhibit replication. So there's a lot of interest in it. The problem is, so far, the randomized controlled trials have had small samples, unclear conclusions. There's only one relatively large study, double-blinded, done in Colombia, which had 400 patients, and they were not able to show any benefit, any effect on outcome with the use of ivermectin compared to placebo. So at this point, NIH says insufficient data, and the World Health Organization says use it only in the context of a clinical trial. So in summary, for all three areas, convalescent plasma, vitamin D, and ivermectin, all await further results of randomized controlled trials to determine their position for use in the treatment of SARS-CoV-2 infection. And at this point should be used in the context of a clinical trial. I think convalescent plasma is a very interesting area, the idea of giving neutralizing antibody, but it needs to be high titer and early on, and we await further data to really understand if it is beneficial. These are my references. Thanks so much.
Hi, I'm Nicholas Janiga, and today I'm going to talk about whether employers and schools have the power to compel COVID-19 vaccination. I first start off by disclosing that I have no conflicts of interest related to me or my immediate family members with any connection to this presentation. An additional disclaimer, I'm a lawyer, but this is not legal advice. I'm offering a framework and discussion of legal issues about mandatory vaccines, but please consult your own legal counsel before taking action. Often people start out too long, didn't read, and I'll give you the lawyerly response of whether employers and schools can compel vaccination. It depends. It's the most lawyerly answer you'll likely find as it goes. And as we're moving into hopefully an environment, perhaps in the fall, that looks more like this picture taken pre-pandemic, an alternate question that we might explore a bit is, even if you can legally mandate vaccinations, is it right for your organization? Whether you're a school, hospital, business office, there are considerations related to culture and logistics that go as a next step beyond some of the legal requirements. We'll focus on legal to start out. And student, I take student and employee a little different, although there's similarities. So focusing on students, there's no current state mandates, but there's many existing laws in most of the states about mandatory vaccinations for post-secondary students. And there's an ongoing list of schools that have been kept and have been announced, over 120 by a last count, that are expecting students to be vaccinated by coming on in the fall, and different variations of that. Public schools have differential and alternate challenges than private schools because public schools are deemed instrumentalities of the state. And there's certain constitutional protections that apply to state actors when it comes to vaccines. SUNY and CUNY, the public school post-secondary systems in New York State, as well as the University of California system, have announced that they will be imposing mandates, but they will only be effective upon full FDA approval of a vaccine. Currently, all the vaccines in the US only have emergency use authorizations, and there are some arguable differences or debates, while it's not completely clear in the system, if there is a difference. So that's something to pay attention to as you're listening. A number of schools that have announced that this will be required, some of them are springing mandates that come into effect. I know I've heard that SUNY is contemplating and anticipating that the authorization for at least one of the vaccines will come through fully from the FDA in time for the fall semester, but time will tell. Certainly there's also active litigation of that issue right now. It's going on in, was filed by an employee at the Los Angeles Unified School District a few months ago. It's moving slowly through the school over whether state actors can mandate vaccines that are only approved under emergency use authorization. So a lot of the legal community has been watching that case very closely to see how it comes out, what the analysis comes. It's moving slowly through the court systems, and there's nothing yet to really glean from the procedural issues, but it has been challenged. This is the second challenge. The first challenge was I guess the parties resolved it was in, I believe, New Mexico by a corrections officer, whether that could happen, but they didn't actually get to the issue and the case was dismissed on procedural grounds. Moving on, there's also state law considerations that have to be concerned. Colleges in Florida can't mandate student vaccinations because the governor signed into law in May prohibiting colleges from asking for even proof of vaccination. So you can't have a mandate if you can't ask for proof. The Texas governor issued an executive order banning organizations that receive state funds from mandations. And flipping around the other side, we're starting to see perhaps some other adjustments. A state senator in New York State has introduced legislation that would make COVID-19 vaccines mandatory for all college students in the state. We'll see where that goes. It's currently in the bill discussion process, and I haven't heard any statements with the governor or others of how supportive, but at least the thought is on minds. There's parallels in the student context that schools are drawing related to requirements in the state, and I've listed a couple here, come from the state requirements for MMR vaccines. And as thinking about making this mandatory, schools are adopting, and you'll hear this, the typical exemptions, a medical exemption and religious exemption, because that's what's in the state laws now, as well as there being a medical exemption requirement rooted in the Americans with Disability Act. Interestingly, Maine and California do not require religious exemptions for students of any vaccines, and Connecticut just passed a law that will take effect in 2022 that ends religious exemptions on that. But as of right now, many people, to avoid that subject, are moving to have the exemptions of both medical and religious grounds and navigating those. Flipping over a bit to the employee population, a lot of similarities, but there are some key differences. A number of, and I'd say growing entities out there are announcing mandatory vaccinations for employees. Generally they're permitted. Yale University has announced it for all of their faculty and staff, and then Penn Medicine, the hospital system, has announced it for all of their employees, and there are a number of others that are going in. The EEOC has issued guidance back a couple months now that didn't really focus on can you not. It talked about when you do, not making it mandatory, and they will not make it mandatory to expect, but sidestepping the question of is it permissible, it's when it's permissible, certain requirements and how to implement it. Public employers though, and you'll notice Yale, Penn, and others are not public hearing, do have these other hurdles that I mentioned too, related to perhaps the free exercise clause, due process clause of the Constitution, and then state-specific prohibitions. Another key logistical hurdle for employers that don't exist with students is if you have any type of unionized workforce, your collective bargaining agreement may require bargaining in order to impose that. I know that when Rutgers came out and was an early announcer that they would require it for students, they had not announced it for employees. And the last I checked, I hadn't heard it for employees. One factor I had heard in the community is that they have to deal with 26 separate unions of their staff. And that was a logistical hurdle in even getting to that point. Last I heard, Clarkson University had announced it for its faculty and staff as a requirement, but was still working out the logistics with their labor unions. So it's a complexity. Labor unions, I think, are generally supportive, but there's factors related to this. In the employee, you still also do have various exemptions. And medical is very strong with the Americans with Disability Act, the requirement of an undue burden. There's also a federal pregnancy discrimination act. So you'll need to consider and whether you're treating people that have concerns and how pregnancy may relate. Is that discriminatory? I know schools and entities have thought about lumping in pregnancy with the medical, or maybe medical may be solely based on pregnancy. There's also religious, and there's specifically a requirement in Title IV of the Civil Rights Act that prohibits employer discrimination on religious basis. Though it's interesting, there's a case law, we don't have time to go into this, that strongly held moral or philosophical beliefs alone are not religious. Although there's another contrary case that someone who wouldn't cover up their tattoos because they worshiped the sun god Ra from Egyptian, and it was suggested that he worshiped with a group of 10 other individuals. It was not a recognized religion. That was enough from the EEOC to require it. There's a lot of confusion. What will you do? Both the ADA and Title IX, as you have exemptions, they have accommodation requirements, and it creates quandaries for employers that have to go to. There's this balancing of undue hardship. There's differences between the accommodations that may apply if someone is applying under the ADA and therefore medical or religious. The standards in the case law are not identical. some of the entities, institutions out there are certainly applying similarities, which it may be easier to administer. And I'll just add by, because I know time is turning tight, there are alternatives, and many institutions are running. Can you use the carrot versus the stick approach? Incentives versus a lottery. In Ohio, they noticed a significant jump in vaccinations when the governor announced a lottery. In New York State's preparing that. Some institutions are offering bonuses, monetary incentives to whether employees will become vaccinated. The EEOC has weighed in. There's some concern whether that's legitimate or not, although it is happening. And the EEOC is planning to weigh in on that. And then there's certainly the idea of, can you get expanded freedoms to proven vaccination, and perhaps changing the feeling about being more open, that you don't have to wear a mask, that you have more freedoms in the workplace or in the school, can be a positive incentive and may not be necessary to fully mandate because you can get the encouragement. So there's a lot more. Talk about your council. There's a lot more, but generally, as I said before in conclusion, many, but not all can in many instances, but you have to evaluate the exceptions and assess your laws. Thank you very much.
Hello, this is your host again, Dr. Edward Halperin, with information for those of you who wish to get continuing medical education credit. You have three options for getting your CME credit from today's program. You can text the code 14GYPS, all capital letters for the letters, to the phone number 828-295-1144. If you text that code to that phone number, you'll get a response back with instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit. If you don't like doing it that way, you can go to the website www.eeds.com, click on the sign-in button, and enter the same code. As a third choice to fill out your satisfaction questionnaire and get your CME credit, you can take your cell phone and snap a picture with your software of the QR code, and that will automatically take you to the place on the web to fill out the questionnaire and get your CME credit. Either of the three ways will work, but I would recommend you get about your business to taking care of this, because the code will expire on Tuesday, June 8th at 12:30 in the afternoon. Perhaps you want to take your phone out and now do a screenshot of this information, or maybe you want to write it down, or you want to go right ahead and do it now to be sure you get your CME credit. Now let's turn our attention back to our program.
Good afternoon, everybody. This is Dr. Padmini Murthy from the New York Medical College School of Health Sciences and Practice. Before I start discussing what has happened in India during the pandemic and why, I would like to express my sincere thanks and appreciation to Doctors Kadish, Halperin, and Amler for curating this very important series on COVID, and express my personal thanks and a privilege for being asked to discuss on what has happened in India. I have no conflicts of interest, and the objectives, which I will go through very briefly, I will talk about the factors which have contributed to the current COVID catastrophe, highlight challenges faced by the Indian healthcare workers, and discuss the national and international response to the current crisis. What are the contributing factors? Chronic underfunding of the healthcare system, and according to a WHO report released, this is one of the recent reports in 2019, India spends only 3.5% of the GDP on the healthcare system. And this is one of the main reasons for the chronic underfunding. Corruption, black marketing, as it's called in India. Unfortunately, the prices for essential medicines and medicines such as remdesivir have increased so much that they're being sold to the highest bidder. Social determinants of health, such as rigid gender stereotyping, do not give access, for women to get healthcare or tested for this, and also lack of basic interventions for COVID patients, such as oxygen, which is the major criteria, a major challenge which we are talking about due to the economic inequities, vaccine shortages. And one of the reasons for vaccine shortages is India has been very slow to authorize the import of vaccines such as made by Pfizer and Moderna, and coupled with they have been exporting a lot of their locally made vaccines to other countries. And according to a report released by Bloomberg on May 22nd, only 3.1% of India's population have been vaccinated out of a population of over 1.3 billion. So these rates are very, very low. Multi-generational households where people live together, and the young millennials go out to work and they bring back the disease to their grandparents and parents. This is a major challenge because 4 out of 10 households in India are multi-generational. Now, looking at this, you can see this gives us a good illustration, and this was updated on May 24th by New York Times to look at how the cases are spiking. This is what is going on, even though the infectivity rate in some places are coming down and the cases are coming down in some places. Overall in India, still the cases are on the rise. What is the current scenario? You can see people waiting online to get their COVID shot. And some of the states in India have said that opened up by saying they will give vaccine available, make vaccine available to people 18 to 45 age group. Unfortunately, due to the terrible shortages, they have not been able to go there and provide access. And there's so many hospitals which have no vaccine available or primary healthcare centers. This further adds to the program. Now, the challenges faced by our colleagues in the Indian healthcare system, and I would like to tell you that this is some, I'm discussing this based on some of the accounts I have heard from my former colleagues and classmates in India of physical and mental support. Many of my colleagues have said they've reached a breaking point. There's a lack of institutional support. A lot of the healthcare workers do not have access to the vaccine, do not have access to the PPE as and when needed to change and go ahead, and also do not have mental support or any other kind of support like days off or increased compensation. This is a major issue. Violence against healthcare providers is an ongoing, alarming public health issue, and there are many healthcare providers who have been beaten up and assaulted by irate relatives of the COVID patients when they die with no protection. And one of my former classmates from in India in medical school told me that his family also received threats. This has increased the stress levels and anxiety. And also they are anxious if they get the disease, what will happen to them, because a lot of times they're the sole breadwinners, or even if they do get over COVID, recover from it, what about the danger they bring and the exposure from to their other family members? And increased fatality among physicians. The Indian Medical Association on May 18th indicated that 50 physicians who were members of IMA died on one day due to COVID exposure. And this is a very small number, as we do not have all the figures. As you can see, the healthcare workers say the pandemic has left them completely exhausted. The community has rallied, and you can see that people are waiting their turns to get oxygen from these oxygen cylinders by faith-based NGOs and other non-governmental organizations. This is a daily scenario. And this woman in one of the most populous states in India, Uttar Pradesh, is having oxygen administered to her in a car, and you can see that how they're checking her pulse ox too. So this is a everyday issue, and people are dealing with it. So some of the national and international responses, I just discussed briefly what the national responses are. Internationally, as we know, US aid, the US government, the UK government, so many governments have been sending supplies, mostly oxygen. And AMVA, one of the NGOs I'm involved with, the American Medical Women's Association, we just launched a very successful campaign and raised funds and sent out oxygen concentrators, which as I speak, were just received in India. We have been partnering with others in India, such as the Tata Memorial Trust, so that this goes very speedily to the network and also to the public hospitals. As I'm wrapping up my presentation, I would just like to say that this is such a sad situation, because not only is it a public health issue, but it is also highlights the social inequities and how the systems have failed the residents. So we all are in this together. And thank you all so much for letting me speak briefly as to what the challenges are. And in conclusion, I hear from my colleagues, and I just heard from them this morning that they are bracing up for a third wave of COVID. They want to be prepared, better prepared than what they were. Thank you very much.
Hello again. This is your host, Dr. Edward Halperin, with a word from our sponsor. Programs like you're viewing today are free. Indeed, the continuing medical education credit is also free, but producing these programs is not free. The college spends a considerable amount of time and money arranging for speakers and slides and the information technology infrastructure to bring you today's webinar. For those of you who are inclined to give back to the college to help programs and research projects like the ones mentioned today, we hope you'll consider making a tax-deductible gift to New York Medical College, because your donation will help offset our costs. Great things are happening here at New York Medical College. We hope you'll want to be a part of it. There are 3 ways you could make a donation. You could phone us at 914-594-2720, and someone from the development office during business hours will be happy to take the information. Or you could go online at www.nymc.edu/give and electronically with a credit card, make a donation to support today's program and our COVID-19 research. Or if you like writing a good old-fashioned check with a pen, please make the check out to New York Medical College, write on the memo line, COVID-19 webinar, and put it in the mail to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking about us during these challenging times. Thanks for considering making a donation. Please stay safe, and let's turn our attention back to our program. Hello again, this is Dr. Edward Halperin, and I'm here now not as your host, but as one of the panelists to provide you with my thoughts regarding the impact of the COVID-19 pandemic on the diagnosis and treatment of cancer. I am the Chancellor and CEO of New York Medical College, Provost for Biomedical Affairs of the Touro College and University System, and a professor of radiation oncology, pediatrics, and history. I have no conflicts of interest to disclose. I'd like to begin my comments by telling you about a patient I saw recently. A young man came to see me with the following story. He was a 31-year-old male who developed a change in stool caliber and blood per rectum in the fall of 2019. He had an appointment to see a gastroenterologist in March of 2020, but the appointment was canceled because of the onset of the pandemic. A family physician was consulted who prescribed iron because of anemia. The change in stool caliber, the blood per rectum waxed and waned, but with worsening bleeding in April 2021, a rectal examination and a sigmoidoscopic examination was finally performed. The biopsy of a palpable rectal mass showed moderately differentiated adenocarcinoma of the rectum. This case raises several important questions. Did the pandemic delay the diagnosis and treatment of a potentially curative cancer? Would the tumor have been caught earlier had it not been for the pandemic? And if it had been caught earlier, would that in the long run have made a difference in what the patient will undergo for therapy? Would it have made a difference in his prognosis? When clinics were closed because of the pandemic, when elective surgery was halted, when medical resources were diverted to the care of COVID-19 patients, were fewer cancers diagnosed, and was treatment for cancer interrupted or delayed? Let's take a look at the data. Here are a series of bar graphs and tables from a recent article in the Journal of the American Medical Association. If you focus your attention on the fact that in the bar graph, all the numbers are negative, what you are looking at is a month-to-month comparison of the first 5 months of the pandemic in the United States to the previous year's same 5 months. And you can see quite clearly that the billing frequency for mammograms, for colorectal screening for cancer, for lung cancer screening, and for screening for prostate cancer collapsed in the first 5 months of the pandemic. You see how mammography went down 49%, 84%, 39%, 9%, 9%. Colon screenings down 41%, 75%, 49%, 25%, 38%. Lung screenings for lung cancer down 51%, 75%. And the same story for prostate screening. Clearly, the amount that American medicine was billing for screening for cancer crashed in the beginning of the pandemic. The relative change in billing frequencies for the administration of chemotherapy and for the administration of related oncology drugs, such as monoclonal antibodies, anti-nausea agents, etc., also went down. As shown in this similar bar graph from the Journal of the American Medical Association, billings and collections for physician-administered oncology products and for the administration of chemotherapy typically went down 20 to 30% in the first 5 months of the pandemic. Screening for cancer went down. Chemotherapy administration clearly went down. Also, the number of biopsies looking for cancer in the breast, in the colon, in the lung, in the prostate went down. This graph shows the frequency of billings for breast biopsy, colon surgery, lung biopsies, modified radical mastectomies, colectomies, and prostatectomies. And you can see in all regards, they went down substantially, 20% to more than 80% decline compared to the previous years. The pandemic is clearly affecting screening for cancer, treatment for cancer with chemotherapy and surgery. There was also a marked drop in the evaluation and management codes for cancer-related evaluation and management because of the pandemic. Year to year, compared to the previous year, in 2020, the E&M, evaluation and management codes for cancer, went down 1/3 to 3/4 compared to the previous year, month to month. There appears to be no doubt that the pandemic adversely affected cancer diagnosis, cancer screening, and cancer treatment. Newly identified cancers in the United States substantially went down week to week. This bar graph shows the number of newly identified cancers week to week from March to mid-April of 2020. And you can see the collapse in new diagnoses of breast cancer, colorectal cancer, but less substantial drops in lung, pancreatic, gastric, and esophageal cancer, probably because they're more likely to present with symptoms than by screening. Did it have to be this way? No. This is data from New Zealand. The cancer diagnoses in New Zealand month to month from 2020 compared to 2019 went down in April and May, but we're back to baseline levels by June and July. It shows what the impact is of an aggressive COVID-19 management policy was upon cancer. Also in New Zealand, cancer curative surgery went down just for the month of April, and it was back to baseline by the month of May. In New Zealand, with an aggressive COVID-19 policy, the impact on cancer appeared to have lasted for 4 to 8 weeks, as opposed to many months as it did in the United States. So were fewer cancers diagnosed in the United States because of the pandemic? Yes. Was treatment for cancer interrupted? Yes. Was treatment for cancer delayed? Yes, it was. Is there a rebound effect occurring? So far in my experience, yes. My oncology clinics are much busier as people whose diagnosis was delayed are now coming in for diagnosis and treatment. As a result of the pandemic, can we expect an increase in cancer mortality rates? Probably, yes. Why did I say probably? Because the impact of a delay in diagnosis and treatment for cancer upon morbidity and mortality of cancer depends on the type of cancer. Simply stated, for a slow-growing cancer with a low chance of metastasizing, or for a cancer which is extremely responsive to treatment, the impact of a delay in diagnosis and treatment will be less than for a quickly growing cancer with a high chance of metastasizing. For cancers which respond poorly to therapy, delay in diagnosis and treatment may have little impact on survival. If COVID-19 becomes a recurrent seasonal disease as a public health matter, we're going to need a healthcare system that will need sufficient capacity to deal with it, whilst also providing care for patients with other diagnoses. Thank you for listening to me. And now let's turn to our question and answer portion of the program, which will be hosted by Dr. Alan Kadish. Do remember, if you have a question, to type it into the question and answer box that appears on your screen, and we'll be monitoring them. It looks like our first question is related to myocarditis in adolescents. It's a question for Dr. Robert Amler. If Dr. Amler could come on. Our questioner wants you to tell us some more about myocarditis in adolescents related to the vaccine, how one should manage it. Dr. Amler, please, the floor is yours.
Well, thank you for that question, Dr. Halperin and the questioner. Myocarditis has been reported as a effect or an occurrence after the vaccine given in teens. Couple of points to bear in mind. First is that this particular presentation of myocarditis is less invasive, less severe than the myocarditis that has been reported from older people getting COVID infection, and is also less severe than teens getting COVID infection. So the vaccine, although there does appear to be a risk of getting myocarditis after vaccination in teens, it is less common and also less severe following the vaccine than following infection. Dr. Kadish is also a cardiologist, and he may want to offer a few additional comments. And thank you for the question.
So I think I would echo what Dr. Amler said. There have been rare cases of myocarditis, more commonly occurring in young men. There may be a couple of deaths worldwide attributed to it, but myocarditis does occur in young men. And whether there's really an excess mortality is still not completely clear. At this point, no one has recommended that young men not receive the vaccine because of the concern about myocarditis. But as with all side effects, as was discussed earlier, scientists and clinicians are continuing to monitor the incidence in different countries. And if there's any change in the recommendations, I think they'll be made responsibly and quickly in order to adapt to the new data that are available. The next question that I wanted to pose, and thank you, Dr. Amler. Next question I wanted to pose from the audience is a question to Dr. DiCaprio. So Dr. DiCaprio, there's been a lot of agitation in the media recently, particularly politically related, about whether or not the COVID-19 pandemic might have begun with a lab leak from the Wuhan laboratory in China. So I'm not going to fully put you on the spot by asking you what you think about that, but I will ask you to possibly review, how do we know? How can scientists tell where a virus or pandemic initiated?
This is a great question. Thank you for allowing me to share some information about this, because it's fairly complex. Now, this topic by itself is an evolving topic, and it's surely of global interest, and many are diligently looking into gathering more information and evidence about it. At this point, we're really there. We're just gathering information, but the requests and pressures for more specific information have surely taken front stage recently. Now, there are a lot of theories: a leak from a lab. There's some being transmitted from animal sources, whether they be live animal like a bat, or even animal meat that was frozen from outside of China. So there's lots of different theories right now, and a lot of these theories are going to be looked into more thoroughly. Now, one way that we can approach this for our webinar today is to kind of take the approach by elaborating a bit on some of the ways that science can look into this topic to gather more data. And so at this point, gathering data through an outbreak response, and also gathering data related to microbial forensics or viral forensics, we kind of broadly call it microbial forensics, is probably an important way of gathering these types of data. And it's going to help trace pieces of information that support the evolution of this virus. So let's look at, first, there are probably two major components that we have to look into. The first is sample collection, which in an outbreak response and microbial forensics are very complex. They can surely be complex. They're not simple. It's not just, oh, let's collect some human samples. You're looking at animals. And not just one or two animals, lots of different animals, even insects. Then there's foods and environmental sources as well. Then we've got to identify and find the target. It's likely that the majority of these samples, the target's going to be viral genome. But what about antibodies? Right? What about antibodies in these animals? That's also going to be important in helping elaborate where this virus came from and how did it evolve? Did other animals get infected and develop an immune response? So there's lots of things we're going to look for. Finally, and probably even more important, is the analysis, the laboratory techniques that are going to be used to help focus on collecting evidence that both helps provide information for investigative leads, but also narrows down potential origins. And these techniques are likely to explore molecular targets and the genetics and viral targets in that regard. But it's going to be really helpful to get this data. Now, the data, it would be great if it provides this beautiful story and this nice fingerprint with a clear delineation of evolution through these sources, but it's not always the case. It's usually what we end up seeing is we just get pieces of the data. And in fact, we're still doing this for lots of pathogens, especially the zoonotic ones. And we still are piecing together information, decades of looking into this for other viruses. Now, hopefully that isn't the case here, and we'll gradually get some information. But unfortunately, at this point, we just don't know. But a lot of work and effort and testing is definitely going to be moving forward in this field. And hopefully we'll get some information soon. Thanks for the question.
Sure. So a quick follow-up question. I won't ask you where you think the virus came from, but how likely do you think is we'll have an answer?
I think we'll get information. Whether or not we have an answer, I really don't know, because from my experience as a virologist and a virologist who worked on a lot of these really kind of crazy viruses like Ebola and Marburg, we still don't know about the origin of those viruses. Having worked on those viruses many, many years and involved in these processes, I don't know if we'll be able to get that clear fingerprint, that clear story that I think many are hoping for. But I do think that we'll get data And it may be enough data for us to gather information to better project public health processes and protocols. And I think that that is something that will gain, hopefully, if the information is enough, something to gain from this, even if it's not the answer everyone is looking for.
Thanks so much.
Thank you.
So there was a quick follow-up question about myocarditis in teens, about whether it's more or less common in older or younger teens. And the reality is we don't have, in order to detect myocarditis, we needed very large population exposure because it's so rare. In Israel, the estimation is 1 in 50,000 cases. And because the vaccine has not been used in large numbers of patients ages 12 to 16, we just don't know yet whether younger teens will be evaluated, will be at risk more than older teens. Next question is for Dr. Amler. Welcome back. What are the chances of fully vaccinated people in public without masking and perhaps without social distancing, either contracting the virus or transmitting the virus?
Well, thank you for that question. The whole point of the vaccine, let's remember, is to induce immunity over a few weeks period of time. So fully vaccinated means at least 2 weeks after your last required dose, either 2-dose or 1-dose schedule. The whole point of that vaccination is to give the recipient immunity to the point where when exposed to infection, they do not become ill and presumably do not develop enough viral load themselves to pass virus on to other people. So the goal of vaccination is you don't get sick and you don't pass the virus on. Although no vaccine is perfectly safe or perfectly effective, a vaccine of this nature is highly safe and highly effective at preventing both of those occurrences, which is preventing infection and preventing passing on infection to others. So the answer, although it's not a numerical certitude, it certainly is that a person who's fully vaccinated is enormously safer from getting infected and from passing the virus around when they're going out and about without masks and without the distancing. And thank you for the question.
Sure, I've got another question for you, Dr. Amler, as long as you're on with us. You had alluded to boosters, revaccination, et cetera, in your comments, and certainly there's been plenty of press stories about it. At this point, is there any evidence definitively one way or another about whether booster shots or additional shots will be required from any of the vaccines?
No, but it's not for a lack of looking. Everyone who's involved in this is looking very carefully to see if there's a waning of immunity or a partial loss of protection over time when you are fully vaccinated. So far, from what I've heard, it is not the case, and that you still have immunity. Even now, people who were vaccinated 6 months ago as part of the emergency use authorization, and I would presume, although I don't know this firsthand, people who were vaccinated during the clinical trials several months earlier, who presumably still have protective immunity. That's a very good sign. What we don't know is what happens in another 3 to 6 to 12 months from now, when there could be a waning of immunity, like we see with other infections and vaccines, that would require a booster shot in order to keep yourself fully protected. The other wild card in all this is the emergence of additional variants, such as the 1.117 coming out of the United Kingdom. And let me see if I get this number right, the 1.167.2, which is newly emerging from India. And I understand from my reading, is now becoming a very dominant strain in the UK, oddly enough. So we'll have to watch these variants as they emerge. I've not seen myself convincing evidence that they have shown themselves to be a major problem yet, but everyone's going to have to continue to watch this very closely. We do know that with influenza, for example, if we don't modify the vaccine about once a year, we will fall behind in being able to protect the population from the newest strains of influenza virus. But again, it remains to be seen. Thank you for that question.
Thank you, Dr. Amler. Dr. Murthy and perhaps Dr. Amler, there was a question about the effectiveness of the vaccine against the variant that was first found in India. And I'm not going to attempt to follow Dr. Amler in remembering the entire notation, numerical notation for it, although that's probably scientifically and perhaps from a public policy standpoint, the best way to do it. But do you have any information from your contacts about how the vaccine has been working when people have been able to get it in India, and in particular against the variant that was first described there?
Thank you, Dr. Kadish. Thank you for the question posed. As far as I know, as of yesterday, that is the 2nd of June, there has not been much information because these vaccines, the vaccines we have here, whether it's J&J, Pfizer, or Moderna, are not available in India. And there is now there's very little data. Again, it's very rough that one of the vaccines they have there, Covaxin, is showing to be effective. But again, that being said, some people who have had their first vaccine before they went to the second dose have unfortunately succumbed. So as was said so beautifully by Dr. Kathleen DiCaprio, one of the challenges is the studies are very rudimentary and we still don't know, and it's evolving. So thank you again for the question.
That's great. Dr. DiCaprio, there are a couple of questions about antibodies and titers that I was hoping that you could help us with. So the first question is, if you have antibodies, do you still need to be vaccinated?
Well, if you've got antibodies from if you've generated antibodies as a result of recovering from COVID-19 infection, the answer is it is recommended. And you should wait about the 90-day period. It's recommended by the CDC to wait 90 days after you fully recovered from the infection to get the vaccine. And the reason for that is the immunity generated from natural infection is we're still trying to weed it out, trying to get a better understanding of its strength, what it's made of, as we are with the immunity generated from the vaccine. So just given that we know that the vaccine is so effective, it is recommended that people who have recovered from infection, whether they've generated antibody or not, regardless of the titer, it is recommended that they do get the vaccinations in the United States.
And a related question, as far as antibody testing is concerned, if the spike antibody tests are negative after vaccination or perhaps even after natural infection, does that mean that patients are not protected from COVID-19?
That's a great question. And it's one that has definitely gained a lot of steam in these recent months as more and more people get vaccinated. It isn't recommended at this point that following vaccination, you go and you get your antibody titers for various reasons. And that has to do a lot with just exactly what the antibody test is assessing. There are lots of different antibody tests available. Some assess nucleoprotein, some assess glycoprotein, and even the tests that do assess for the spike protein of this virus, there are multiple epitopes and different antigens that those assays will assess. And for proprietary reasons, we don't always know exactly what they're testing against. Given that information, assuming that people who do get vaccinated, they just, and we are using the correct antibody testing to get an accurate picture, and they lack antibody, it's important to keep in mind that the immune system has multiple arms of immunity. Antibody is just one of them. There's also a T cell response that comes with immunity, and that we're still trying to have a better understanding of. So just because you don't have antibody, regardless of the test that you get, that doesn't necessarily mean that you are not immune. And I do know that there are some assays that are being explored at this very moment, and hopefully we're going to be getting some information about those T cell mediated assays. So we'll be able to gauge more information about someone's immunity following natural infection infection and following vaccination on the other arms of the immune system. And so we'll definitely be able to get a better idea, because that information will likely help people make decisions. Do I get a booster? Do I not get a booster if it's necessary? Do I need to get the vaccine again? Am I immune? So it's going to give us more information in the upcoming months. Thank you.
Sure. There was a question that I'll take, because I guess it's directed at me, which was a question, will New York Medical College and Touro College require vaccination going forward? So the answer is a qualified yes. If you look at the big picture, the answer is we will require vaccination of everybody on campus. There will be, of course, the kind of exceptions that Nick Janica talked about, and we may introduce some additional exceptions as well. Final policies are still being worked out, but for those who are associated with Touro New York Medical College, we hope to announce them soon. And as Nick Janica said, you should check with your counsel. And since Nick Janica is our counsel, Nick knows that we'll check with him. Nick, did you want to add anything about that?
I'm here to be checked with, and thank on that. But I might, Dr. K, should mind take one question that came up in someone asked during my presentation. How do items reflect and relate of mandatory vaccines of COVID versus MMR vaccines? And if I just would steal a minute, I'd share that MMR and other vaccines have been approved and mandated by legislatures across the country, and we are required, as all schools in New York State are required, to require those and mandate those vaccinations. As I pointed out, to date, no state legislature has yet required that for COVID. Time will tell how that changes, and definitely there's some different views by politicians of whether that will ever happen in some states out there. Thanks, Dr. Kadish.
Sure. And Dr. Halperin or Dr. Amler, Nick told us about the legal aspect, because this was another question that was asked. From a medical standpoint, Dr. Halperin and Dr. Amler can weigh in as well. Do you think there's a medical reason to treat COVID-19 vaccination differently from MMR vaccination? Of course, all that assumes that the school children are over 12 with our current data, and perhaps in the future that there are data using the vaccines in younger patients.
You want to go first, Rob, and then I will follow?
Sure. It's been a long time, if ever, that measles, mumps, and rubella killed 600,000 people in one country in 1 year, namely ours. So the lethal aspect of COVID infection has to be considered, just like the very serious consequences, most of them non-lethal, of measles, mumps, and rubella are also considered. In requiring MMR vaccine, particularly in any healthcare and health education institution, we have to think about transmission of infection to our patients coming from our students as well as our faculty. So there are many intersecting factors with COVID. As I said in my talk, we can compare COVID to pertussis, to measles, to meningitis B, to smallpox, to polio, to many other infections for which we mandate vaccines at various times. But from my own point of view, COVID is a very serious infection, very transmissible. It's wreaked havoc on our populations as well as on our ability to deliver education. And so I think it's very deserving of mandates, depending again on the legal frameworks and the policy frameworks that are set forth by the elected officials and the trustees of our institutions.
I would simply add to what Rob has said, that if you look at the history of American vaccination policy, our adoption of widespread MMR vaccination and the war against smallpox were very much driven by the concentration of children in public schools and its effects of the diseases on children. Mercifully, so far, the mortality rate of COVID-19 in children is very small, but Americans were motivated to push for MMR because of the devastation of these particular diseases in children. It was a different time and a different situation. Obviously, the same thing in the history of vaccines went for polio. Americans being fearful for the safety of their children in public swimming pools, etc., was the motivation for polio. Americans take attacks of viruses on children, it seems, in our history, differently from that on adults.
Thank you, Dr. Halperin and Dr. Amler. There's next a question, which is, was a lot of press about an unfortunate tragedy in Israel where 45 people or so died when they were closely packed in on a minor holiday celebration. And one of the questions was there an increase in the incidence of COVID-19 seen after that event? So that event probably happened about 3 weeks ago or so. And sometimes it's taken a little bit longer for it to become apparent that there's been an increase in infections after gatherings. However, to date, the incidence of COVID-19 in Israel continues to decrease. Obviously, you have to superimpose that event where people were crowded together with the increasing in herd immunity in Israel because of their early vaccination program. And so I don't know that we can ever say with absolute certainty that no one was infected, but so far there does not seem to be a signal of increased infections after that event. And the likelihood is that through a combination of the vaccination rate, which in adults is well over 50%, and the post-infection immunity rate, the post-COVID infection immunity rate, even though, as Dr. DiCaprio mentioned, that immunity is not as good as with the vaccine, but when you add those together, it does appear that Israel has reached some degree of herd immunity, and they've seen both a decrease in the number of cases, and they are now feeling comfortable enough to release restrictions, which by July 1st will be almost absent in Israel, assuming the current trend of daily decrease in infections continues. So the hope is that this sort of would be will be a kind of natural test of achieving herd immunity. And we'll hope that that infection rate continues to stay low. Dr. Amler, there's a question about kidney transplant patients. Would you recommend vaccination in a patient who's received a kidney transplant? And of course, obviously, it depends to some extent on what immunosuppressive drugs the patient's still on. You're muted, Rob.
It happens at least once in every webinar, right? I guess I was the one. That's an excellent question. With a very specific situation like this, where someone has been sufficiently compromised in terms of renal function that they had to get a kidney transplant, and now they have an organ that is from another person's body and is going to trigger immune responses that have to be suppressed. This is going to be a very, very closely held question to address to the group of clinicians taking care of that person. I would not want to venture a comment about individualized medical care in a very specialized situation like that. But again, the issues will be any other underlying disease that they have, including the immune suppression, that would put them at greater risk for COVID infection, and the degree to which vaccine could be effective in person with altered immunity, and the degree to which, once successfully immunized, that person would have a sufficiently better coverage and protection against the virus that that their personal benefit outweighed their personal risks. Without the full clinical details, and even with the details, it will be a more complex decision to make. But an excellent question. Thank you.
Thank you, Dr. Amler. And the last question of the day is going to be for Dr. DiCaprio. Are women taking oral contraceptives at higher risk of blood clotting from the J&J vaccine? And would you recommend one of the other vaccines in that circumstance?
Very similar to Dr. Amler's question, it really will depend on the individual patient and their medical situation, because just being on oral contraception could predispose them even without receiving the vaccine, to certain preconditions or consequences. So in those situations, if there's someone that is concerned about that, I would recommend speaking with their individual physician and getting that individual patient care that's necessary to answer that question better. Thank you.
Thank you so much, Dr. DiCaprio. So that concludes today's webinar. I want to thank the audience for both attending and asking a very complete series of provocative questions. And we've tried to answer those that we can. I've said at the end of every webinar, perhaps this will be the last one, but I think we're not quite there yet. So we hope to see all of you again in a month or two, as we have more information on what hopefully is the winding down of the pandemic, not just in the United States, but in the world as a whole, and have more follow-up information on long-term effects of the vaccine in terms of whether we need additional vaccination or not. Thanks again, and thank you so much to the panel for great and clear presentations across the board. Have a great day.